thank you very much. And Vinay, we're going to come back to you after this, actually. So, it's always hard to have a viewpoint because there's so much controversy about it. And, all the time you want to be so cautious with what you're doing to these patients, So, one of the important things is that what are the indications? We've been debating about this for a long time. And so one is that symptomatic PACG, that elevated intraocular pressure not responding to medical management, and there's no benefit of laser PI when you choose to do a laser PI. Elevated intraocular pressure even without significant optic disc damage and not responding to medical and laser management. Then you have PACG with significant glaucomatous damage and elevated intraocular pressure with medications. And you have PACG with glaucomatous damage on multiple medications but non-compliant or non-tolerant to medication. So there are various ways in which these patients present to you, and so in extreme long-standing cases with significantly elevated intraocular pressure, we sometimes also consider an RD glaucoma implant along with lens extraction, because we've had this experience that although we've done a significant number of combined surgeries, somehow it's a great challenge to get the glaucoma surgery to actually be effective and work long term. Glaucoma surgery, as Dr. Surinder pointed out, can always be done as a second option if pressure reduction is not considered significant following lens extraction. So not doing glaucoma surgery with lens extraction in such patients may not be considered to be wrong, actually. Lens extraction with minimal medication to control intraocular pressure post-operatively is considered very acceptable. That's what all the cases shown here and studies shown here have also shown, actually. Significantly elevated intraocular pressure for several days and weeks will result in optic disc damage over several months, even after control of intraocular pressure. Therefore, there is somewhat, it's not an emergency, but there's somewhat of an urgency in managing the PACG and in reducing the intraocular pressure in whichever way you choose to take. An advantage, and perhaps the big advantage, is that the optic disc in PACG undergoes damage at high pressures, but not at intraocular pressure within the normal range. So if you had a POAG patient with a pressure of 20, 21, you'd be thinking that that's too high for this patient, but that's not the case with PACG, because these optic discs are only sensitive to very high levels of intraocular pressure. So this is a lady who was a teacher, and it's almost 15 years now. She came in the left eye with intraocular pressure of 45 millimeters of mercury. Her angles were closed. She had 80% cupping with rim pallor, and she underwent cataract surgery. She's still doing quite well with beta blocker and an intraocular pressure of 15 millimeters of mercury. And this is another patient that we had in the last year. And in the right eye, she had typical signs of angle closure with elevated intraocular pressure. And we tried a lot to see whether we could reduce the intraocular pressure, but it didn't work out very well. And ultimately, we had to go for cataract surgery in this patient. And this was the 6-month effect, actually, that you can see the disc on the left-hand side, the right eye, disc, the disc still looked quite healthy when she came. And then this is the disc at 6 months of follow-up, because she had 15 days of elevated intraocular pressure, before and after coming to us. The time that it took, a week that it took for us to decide that the pressures were not getting under control, we had to do something. So that's the impact. If you have pressures of 50 and 60 millimeters of mercury for a week or more, then you should anticipate that there will be continuing optic disc damage that will manifest 6 months or more later, even though you have reduced the intraocular pressure by doing whatever surgery you choose to do, actually. And you can also see the significant loss in ganglion cells over this period of time. So just, a broad guidelines. So if you have 360-degree sanicid closure, but also remember that, as I think Dr. Surinder showed, that sometimes the sanicid closure on the anterior segment OCT and gonioscopy, but once you do cataract surgery, a part of the angle, actually the iris falls back and the angle appears to open. There is glaucomatous optic disc damage. You'd like ideally reasonably well-controlled intraocular pressure, but that's not always possible. And if you have chronic angle closure glaucoma with generally quiet eyes, I think that's the eyes being very kind to the surgeon. You should be a reasonably experienced surgeon. And as we discussed, it may or may not be combined with trabeculectomy, depending on the severity and duration of the presentation. And please do microincisional cataract surgery, use a foldable intraocular lens, and lastly, you are the person who has to take a decision. And as I always say, you know, when in doubt, if you think that you can do something safely for the patient, then it's wonderful when you create the evidence yourself in your own clinic or in your own practice. Thank you very much. And may I ask Vineet also to please give a viewpoint?
Yes, I think you all covered all the points. These patients also a good idea to dilate with atropine and also give mannitol preoperatively. The mannitol just helps dehydrate the vitreous, not so much for the intraocular pressure reduction as much as it dehydrates the vitreous and gives you that little more space where you can work.
You had a question.
Sir, if there is synechia, then while doing cataract surgery, can you give a air tamponade into the anterior chamber to break the synechia? Does it affect air in the anterior chamber? Does it affect the release of the synechia? PAS, peripheral anterior synechia.
So, like I showed in mine, I didn't need to do anything. That's why I went to check. Now that we have intraoperative gonioscopy, so I went in to check and I hadn't done anything, but the angle had opened. So, now that we have intraoperative, you can see if it's not there, you could probably put viscoelastic or just a iris repositor and just tap it down. But most of the time it would open just with your raised pressure, which happens when you inject saline or viscoelastic into the eye.
So second question, sir, without doing laser PI, YAG PI, directly can you take the case for cataract surgery? Because
yes, I didn't do a PI in the second case because the patient was willing to go ahead with a cataract surgery. So I didn't do a YAG PI because you're removing the cause.
then how do you dilate, sir? What time do you dilate?
The angle closure doesn't occur while dilating, it occurs while returning back, because while it's returning it's slower and your iris lenticular contact time is more. So it doesn't matter.
Thank you.
Yes.
I would just like to share one of my patients. This gentleman had a bypass surgery about 3 months back. So he's on all the platelet drugs. So, and he has angle closure glaucoma and very thick iris. I tried doing very thick iris. I tried doing YAG capsulotomy, YAG iridotomy, and it is not opening up. I failed in both the eyes. So now I think he needs either a cataract extraction, and medically, with medical drops, he's under control. The pressures are under control. And now I'm planning to do a trabeculectomy or a combined plus minus phaco surgery for him. So now, since he's on antiplatelet drugs, I can't take up the case at least 6 months down the line. So for the time being, I'm just following him up with the medical treatment. So what is your advice on this?
Yes, so like we were discussing, I think it would be safer to go ahead with just a cataract first, and then if it doesn't reduce your pressures enough on a second sitting, you could.
But only problem is that he's on heavy anti-platelet drugs.
Cataract surgery we don't stop. Okay. In trabeculectomy we may still stop because of the bleeding, but sure. Cataract surgery we don't stop. So it actually makes it easier for you to just do a cataract surgery first. It would increase the space.
And sometimes when they are on antiplatelets and PI is also difficult, you can go ahead and do a gonioplasty. It works beautifully. I had shown in that also. You can bring down very high pressures very quickly within an hour. It will be normal.